Good morning, everyone. So glad that you are joining us for this morning's second day of the GPS Navigation for Caregivers Conference. We have a lot of great information to share with you this morning. We are so glad that you are here and joining us. We hope that you have survived last week's terrible weather and that you are doing okay. If you are in need of anything during this time, we ask that you can contact us at Age of Central Texas. You can contact Riverbend Church, and we will help put you in touch with the resources that are available here in the community. My name is Rob Fabian. I'm the Director of Marketing and Communications at Age of Central Texas. We are a regional nonprofit organization, homegrown right here in the Austin area, and we provide education resources and programming for both older adults and for family caregivers. We are very excited that Riverbend Church asked us to be a part of this year's 8th annual GPS conference. And it's my pleasure to introduce you to Sharon Butler from Riverbend Church. Sharon's going to tell us a little bit about the history of this conference and about the church itself. Sharon? Sharon, you'll need to unmute yourself.
Need to do that, don't I? Okay. On behalf of Riverbend Church, I would love to welcome you this morning to our 8th annual event for caregivers. This has been quite an exciting road for us the last 8 years, having this conference at Riverbend, and then this year being able to do it virtually. We're really happy that you can join us this way. This was started by a group of folks at Riverbend, all as volunteers who were caring for family members and realized the need in the community. And it has grown every year, and we're really excited about the future and the things that we have going on for our seniors. At Riverbend, we have a support group for caregivers that meets every week, and we have a once-a-week free respite program that will be kicking off later this year. So if you have an interest in either one of those two things, there will be information in your virtual program, as well as an opportunity to share your information with us on your survey that you will get probably on Monday. So we'd love to hear from you if you are interested in those two things. I would really like to welcome Cindy Cummings, and thank you so much for being our presenting sponsor this year, and to Arden Courts for sponsoring this session this morning, and really looking forward to hearing what Sarah has to say. So if I may, I'd like to open us with a short prayer, if you'd like to join me. Father, we thank you so much for the opportunity to come together this way with our technology to share information, to uphold one another, support one another, encourage one another, and to get the information we need to do our job better. Today, as we learn more about dementia and the types of dementia, I ask your special blessing on those who are caring for someone in that difficult situation. It's so challenging. And we really ask your favor on those caring for family members and for their loved ones. Help us to find the joy in the journey a little bit every day, and some nuggets of knowledge that we can use as we go forward. Please know that we are doing the very best we can, and we need your help. In thy name we pray, amen. So we invite you to go to Riverbend website, www.riverbend.com, and you can see what all is going on there. We have so many things going on with this pandemic and the winter storm that we had, and volunteers, and we are meeting in person on Sundays and also virtually. You can see all that on the website. And we're all about inclusion and encouragement. So go see where we can be of help to you in your journey as a caregiver. It's a tough one sometimes, and I'm glad you're here.
Thank you so much, Sharon. Yes, I echo. We are very glad that you're here. And we are also very glad that Cindy Cummings is here. As Sharon mentioned, Cindy is with Turnkey Transitions and Coming Home Team, and she is our main sponsor for this year's conference. Cindy, we thank you so much for your support and all that you've done for so many years in the community to help both older adults and their families. So tell us a little bit about your company.
Well, thank you, Rob. When the opportunity came to be a sponsor, I just jumped on it because I believe so strongly in these kinds of events. And I'm not planning it, so that was fabulous. I know how much work it takes. Rob and I have done many events together, and to just be able to be a sponsor was really a gift during this very trying time for everybody too. So I thank you so much. Again, I'm with Cummings Home Team, and I have an ancillary business, which is called Turnkey Transition. It's an interesting business in that what it does is it helps people when they're moving from a home to a community. We're basically a project manager, and we help people make those transitions so they don't have to call 15 people like people are having to do right now, you know, with their homes and damage and things like that. They just have one number to call. And we help with the entire transition. We help with downsizing. We help with estate sale planning. We help with packing, moving. We do unpacking, and it's actually kind of a big reveal. We'll have our clients go away for the day. We'll meet the mover there at the house. We'll help the mover pack everything efficiently. We'll get to the community and we unpack everything, put the pictures on the wall, and then we'll have our clients come in the door and they'll scream with delight. So it's been a really great offering to have. What we found is people have lived in their homes for, it could be 40, 50, 60 years, and they just have accumulated a lot of stuff. And the stuff is what holds them back from actually being able to move forward and make a move. I've gone through special training. I'm part of National Association of Move Managers, and I'm actually considered a downsizing coach. I'm certified as a downsizing coach, which you wouldn't think somebody needs that, but if you're trying to move and you've got a house full of stuff, you definitely can use that help. And it's great to have a third-party person. We don't want to be bothering our family with things like that. So having a third-party person, it gets done a little bit quicker. So in a nutshell, that's what we do. I'm basically a real estate agent who specializes in those who are over 55. And we've added this extra business so that we can make it easier for everybody. But again, I'm just tickled that I can be here. I'm so happy to hear what Sarah has to say. And thank you again for allowing me to be a part of it.
Thank you so much, Cindy. And we really appreciate everything that you've been doing over the years to help support the community. You're just really a blessing for all of us, and we really appreciate you very much. And when the time comes that your loved one needs to move to a community that can support them, we hope that you'll get in touch with our session sponsor today. Shauna Wheeler is with Arden Court's Memory Care Community, and they are one of our wonderful supporters in Central Texas as well. So, Shauna, I want to give you a chance to talk about what makes Arden Courts so unique and so special.
Oh boy, do we have an hour? Actually, a wonderful place. It's a beautiful community. We are specifically designed for people with dementia. So everything from the way our houses are designed to the bedrooms to our programming, everything is about their success and safety. We've been proudly serving our residents for 20 years here at this location. We'll be 21 years old in November. And we have staff that has been with us for years. Our director of nursing, Odessa Rice, is phenomenal. She makes sure that all of our residents are happy and healthy. We have a lot of resources for caregivers. We have a memory cafe that meets twice a year or twice a month. We also have a virtual support group. So if anybody wants to get any of that information from me, email at austin@arden-courts.com and I will get you the information for that. We also have books. We have a library. This one is wonderful. It's The Alzheimer's Spouse by Mary Kay Doyle. She's a wonderful author. She went through this with her husband. She had her husband in an Arden Courts in Indiana. And also the most famous book we got out here, Tam Cummings, Untangling Alzheimer's. They are free. If you want a copy, please email me and I will make sure you get any kind of resource that you need as a caregiver at home. We're here to help you.
Wonderful. And you guys are located right off of McNeil and 183?
We're right by the fire station and right by Belcones Country Club.
And it is a beautiful community. I've been there numerous times, and Arden Courts is such a tremendous supporter of the community, offering lots of great education opportunities throughout the year, and just an amazing place. So we certainly hope that if the time comes that you need a place for a loved one who is having memory issues, then please check into Arden Courts, because they are just fantastic folks. Shauna, thank you so very much. We're so appreciative of you guys being our sessions sponsor for today. Now, going to do some very quick housekeeping for you guys. As you know, this is one of the first times that we have done the GPS conference virtual. And so if we have a few tech issues along the way, please forgive us. We know that everybody suffered through last week's storm with no internet, no electricity. And so we were able to get ourselves all back up and running by yesterday's first presentation. But we know that there's still a few little burps that happen here and there. So if something happens, please forgive us, but know that we are recording today's session and we are going to post it on YouTube. So if anything happens on your end that you get knocked out, don't worry. We're going to be sending you the link to that YouTube video, and you'll be able to go back, watch the whole presentation. We're also going to provide you with the PowerPoint from Sarah's presentation today. We're also going to be sending you the link to the electronic program. There's going to be tons of great information in there. All of our sponsors have information that will be listed in there, so you'll be able to find that in addition to the bios for all of our presenters today. We're also going to be sending you some great caregiver resources. So we're going to be sending you a lot of wonderful information. Most likely that's going to be coming to you on Monday, because last week we lost a whole week of being able to prep for this week. And so we're still finishing everything up. But we're going to send all of that to you so that you will have in one place the list of all of the YouTube links for all of the presentations, all of the PowerPoints, the program, all of that great information. We're also going to be sending you a survey, as Sharon mentioned. We ask that you please take this survey very seriously, because it gives us the information to help us plan for next year. And believe me, we read every single survey. So tell us what you need as a caregiver. What can we bring to you for next year's conference that can help you in your journey? And we always want to remind you that all this great information is wonderful, but it may not address where you are in your journey and what you need. And so we have great resources here at Age of Central Texas, at the Riverbend Church. All of our presenters are here to help you no matter where you are in your journey. And always remember, there is no shame in asking for help. Every one of us at some point in our lives need help. And as caregivers, and especially as dementia caregivers, we know how difficult that is. Many of us that are on today are caregiving for somebody who has dementia. So we are in your shoes. We know what you're going through. And so there is never, ever any shame in asking for help, because that's why we're here. That's why we do these presentations. That's why we do the conference. And that's why our organizations exist, is to help you. So let us help you if you need it. It is my pleasure to introduce Sarah Hyde-Williams, who is our presenter for today. I've known Sarah for a number of years. She is an amazing expert when it comes to memory care and dementia. She actually has more than 20 years experience working with seniors and with their families as caregivers, both as a community resource and as an elder care professional expert. She has worked in assisted living communities and dementia supportive communities. She's worked in home health and in hospice. And she is a state certified assisted living manager, a certified dementia practitioner and trainer, a certified Montessori dementia care professional, and a certified dementia care manager. And on top of all of that, she currently serves for the Central Texas area as Lewy Body Dementia Association facilitator and educator. Sarah, we are so grateful that you have the time this morning to spend with us to talk about memory issues, and specifically, is it dementia? So I'm going to turn it over to you.
I did the same thing Sharon did. I started talking without unmuting, didn't I? Well, let me share my screen with you so that we can put this presentation up here. Let's see.
And Sarah,
There we
while
go.
you're doing that, I realized I forgot one very important point, and that
Yes.
is that for all of our participants, the chat feature that's located down at the bottom of your screen, it looks like a thought bubble like you would see on a comic strip. Click on that chat feature, and while Sarah is doing her presentation, ask your questions, because this is why we're here, is for you to answer your questions. So ask your questions during the presentation, and when Sarah is finished, we were going to answer your questions live. Now, we are a little restricted on time. We're going to end right at 11:30 as we promised. So if we don't get to your question during the presentation, we're going to contact you personally and answer your personal question. So please ask those questions, because you've got your experts right here today who can help you out. All right, Sarah, it's all yours.
Awesome. Thank you, Rob. What an absolute honor. When Sharon approached me to be a speaker, I absolutely jumped on it. This is my favorite presentation to give. I see a lot of light bulbs go off when I give this presentation and I speak with care partners, and they know something is just not quite right. They just can't put their finger on it. So an awful lot is put out about Alzheimer's. And when it's not Alzheimer's, we begin to think that there's something a little bit more. And so we're going to cover a couple of different things. Rob did a beautiful job of stating my credentials. I started in long-term care, assisted living, dementia supportive communities about 20 years ago, and I was absolutely hooked by dementia. And I vowed that that would be my life's work. And specifically about 5 years ago, I was beginning to see a lot of these more challenging, misdiagnosed dementias. And I connected with the Lewy Body Dementia Association and became a facilitator here in Austin. And when the main facilitator stepped back, I took all of those groups. And so we do our groups online. I love to educate. I have a 1-hour presentation just for Lewy body on my website if you are interested in that. And my very last slide will give you that website. So what we're going to talk about today is a little bit about Alzheimer's to try to set the scene for us. But we're really going to talk about vascular dementia, the spectrum of dementia with Lewy bodies and Parkinson's disease dementia. And then we're going to talk about this entirely huge spectrum of what we call frontotemporal lobar degeneration, in very short, frontotemporal dementia. So we're beginning to see a lot more dementia these days. And back in the 60s, it was cancer. Back in the 80s and 90s, it was mental health. And so really in the last 10, 15 years, we've made huge strides specifically in the realm of dementia. And it doesn't carry this stigma that it did 15, 20, 30 years ago. So simply put, not necessarily does dementia equal Alzheimer's equal memory issues. Dementia is a decline in thinking skills that interferes with your everyday life. So those everyday things that you do, go to the grocery store, keep a marriage and a home, keep a job, all of those things are, when it begins to impact that everyday life, is when we begin to think something else is up. And that's where my favorite phrase of saying, that's a great question for your doctor. That's when you begin making note of those things and you go back to your doctor and say, these are some of the things that I'm noticing. So not necessarily does more older adults equal more cases of dementia. So when I stated that wrong, yes, we are beginning to see more older folks. We have 10,000 folks per day turning 65. And so absolutely, as we begin to see our population age, we're going to see more impairments in cognition. We're also getting much, much better at diagnosing it. So as a care partner, you're choosing to spend an hour, hour and a half with us today, educating yourself, which makes you better at caring for your loved one, going to your doctor, asking questions, and getting a proper diagnosis. It is one of the fastest growing diseases processes that we're seeing. And currently about 24 million people worldwide are living with a diagnosis of dementia, and that number is to triple in the next 20 years. So we're going to see a lot more of this. And where I say it is everyone's concern, what I mean by that is it impacts every segment of our population: banking, legal, medical, every single segment you can think of. We are beginning to look out for others, our neighbors, those that we sit on the pew on Sunday with. We are all looking out for each other, and therefore it's going to impact every segment of the population. So let's step back just for a second. When you begin noticing some of these things that don't seem quite right, you go to your doctor, maybe your primary care physician. If you already have a neurologist, bring these things up. In that evaluation, what they will more than likely do is maybe a quick test, what's called an MMSE, a mini mental, or a MOCA, an Allen cognitive, maybe in the office, but they're also going to run some blood work to see if there are other things that could be causing this difficulty in cognition that may not be a dementia. So what we want to do is weed out every single thing that is not a dementia before we begin going down this road. And so what we do call those, when we find those, are called pseudo dementias. And think mind, M-I-N-D, metabolic syndrome, renal and hepatic, which is liver and kidney dysfunction. We see a lot of hypothyroidism causing cognition issues, difficulties with calcium, sodium, infections. One of the biggest ones we see is urinary tract infection, yes, but also Lyme disease, hydroencephalus, those types of things. Nutritive deficit. I think I have someone right outside, so if you hear some noise, I apologize for that. Nutritive deficits, those B vitamins, when we're deficient in those types of things. And then, of course, Wernicke-Korsakoff is a sort of dementia also that is related to this. And then, of course, drugs, pharmaceuticals. We are taking more medications these days, and a lot of these medications are causing these difficulties in cognition. I put down at the very bottom alcohol and recreational drugs, because we find oftentimes through the course of a cognitive impairment that folks are self-soothing, and through alcohol and recreational drugs. So when we begin deep diving into, yes, this is a type of dementia, there are 50 different causes or factors for dementia and nearly 120 different types of dementia. Alzheimer's, of course, being the number one diagnosed, the most diagnosed. Somewhere between 50 and 80% of all cases of dementia can be attributed to what we oftentimes call the Alzheimer's disease type. And so second in that, in those numbers is vascular dementia. Unlike Alzheimer's disease, Lewy body, and frontotemporal, vascular is not a progressive neurodegenerative disease process like we see the others. Vascular, and we'll get into that in a moment, accounts for somewhere between 10 and 20%. We're beginning to see Lewy body on the rise. This is the second most common neurodegenerative disease that we see amongst dementia. I put very, very conservatively 5 to 10%. We are beginning to see that number inch up. Some would even say 20%. There's a research study that was put out about a year ago that indicated that about 50% of all the brains that were autopsied had some sort of Lewy body. Frontotemporal, somewhere between 4 and 20%. And then we see these mixed dementias. Sometimes these concurrent. We're not seeing pure dementias very much. We're beginning to see a lot of disease processes altogether. So before we can talk about what is not Alzheimer's, we have to further define what is Alzheimer's disease. Like we said, it does account for about 2/3 of all dementias diagnosed. And like I said earlier, not necessarily as dementia, Alzheimer's is memory issues. So think of it this way. Alzheimer's disease is dementia, but not all dementia is Alzheimer's disease. So to properly say this, and I hear a lot of professionals say this as well, Alzheimer's and dementia. The proper way to say this is Alzheimer's disease and related dementias, because Alzheimer's disease is a form of dementia. It was discovered by Dr. Alois Alzheimer in the early 1900s. So you had, in essence, kind of a consortium of thinkers of that time, researchers in the early 1900s. Dr. Pick, Dr. Alzheimer, Dr. Lewy, Dr. Parkinson, they were all working on what was at that time referred to as senility. And they were trying to figure out the root cause of what was going on with these folks so that we could get better treatments. So what he did find at that time was these tangles, these plaques that we refer to as Alzheimer's. So at its very neuropathological essence, it is amyloid plaques. There are these tau proteins that form into these long tangles within the brain. We find that through CT and MRI an awful lot of times, the what we call an atrophy of the brain, which is meaning the shrinking of the brain and decreased white matter. So some of the signs and symptoms of Alzheimer's disease is short-term memory loss. We see an awful lot of this. It affects the hippocampal region to where those short-term memories are not brought back into that long-term memory bank. And therefore, some people will ask the same question over and over again. They're making lists, trying to keep themselves on task. Poor organization, poor decision-making, poor judgment. We also see some visuospatial difficulties in they're getting lost in familiar locations. That's typically one of the first things that we see as well. Non-recognition of common objects. So they've brushed their teeth all their life, but for one reason or another, one day they'll wake up and not recognize what the toothbrush is, think it is a hairbrush or some other object. One of the definitive pieces to an Alzheimer's diagnosis is there's a lack of movement disorder. So that's typically what we look at when we see Lewy body dementia, Parkinson's disease dementia. And typically what we see diagnosis of Alzheimer's is 65 and older. However, I will put in one little note here. We're beginning to see some genetic links. Chromosome 1, 14, and 21 is this older onset Alzheimer, to where we see on chromosome 19 is the genetic Alzheimer's disease that can affect individuals within their 30s. So it's a much different diagnosis in the age process. So we've talked about what Alzheimer's disease is. Let's talk about when it's not Alzheimer's. So vascular dementia. It is different than the other dementias in which it's, in essence, at its very core, a lack of blood flow in the brain. It is not one of the progressive neurodegenerative disease processes. And some of the factors that we see that go into this are age, diabetes, metabolic syndrome, a long history of smoking, stroke, TIA. And so memory is affected, but also for a proper diagnosis, we need to also see some other form, another portion of some cognitive dysfunction. So typically vascular dementia, we see, I put up here that we usually see it in the old. As our bodies age, we begin to see some of these cerebrovascular, cardiovascular type factors that go into this. And so as folks age, we see this a lot in 80s and 90s. However, because of our Western culture, these factors surrounding the way we live in our culture, we're beginning to see that number come down. So oftentimes we don't see vascular as a standalone dementia. We oftentimes, not always, but we oftentimes see it in combination with either Alzheimer's disease or Lewy body. It depends on all the factors that are going into this, but we typically see it in combination with another dementia. And what's also very, very common for these folks is to have some depression and some anxiety, that mood dysfunction that goes along with this. One of the very core indicators when we're looking at long-term care and how we don't see this progressive slide with vascular dementia, we see that there's some event. And there is a statistic that folks that have stroke or TIA, within about 3 to 6 months, we begin to see those folks have some severe cognitive impairment. So there is this event, and we see this sudden drop in cognition, and they can kind of hold their own and find that new normal for a while, and then we see that plateau, and then we see another sudden drop. So it's like a stair step, typically when we're beginning to see vascular dementia at play. So this is going to be the only slide. Vascular dementia is pretty straightforward. And so we're going to move on to Lewy body and then frontotemporal. So Lewy body, of course, is my love. It's where I love to educate. If you are looking for more information about Lewy body dementia, I have a 1-hour presentation on my website specifically about this spectrum of Lewy body diseases. So it does include dementia with Lewy bodies, Parkinson's disease dementia, multiple system atrophies. We don't hear too much about multiple system atrophies as much as we do the dementia with Lewy bodies and the Parkinson's disease dementia, but I tacked it in on here in case you hear that terminology with your neurologist. I said earlier, this is the second most common form of progressive neurodegenerative brain disease. So in essence, irreversibly, the brain is going through a slow death. And so when the brain can no longer tell the body what to do, that is when we see the end of the prognosis of this disease process. An awful lot of people will ask me what the prognosis for Lewy body dementia is. The average is somewhere between 5 and 7 years for Lewy body. So at its very core, the pathology is that there is this protein called alpha-synuclein, and it deposits or aggregates in these bodies named Lewy. And it was named after Dr. Friedrich Lewy in the early 1900s, who discovered this working alongside with Dr. Parkinson. And that's why they both found this alpha-synuclein, and there we typically see, and we'll go in the next slide, about what comes first and what is the proper diagnosis for that. Lots and lots of damage to multiple regions of the brain is what we're looking at. A new diagnosis, I wouldn't say new, but we're now beginning to refer to it as diffuse Lewy bodies, which means it's covering the cortex of the body, not only frontal, temporal, parietal, but specifically occipital as well, all the portions of the brain. It's very misdiagnosed, oftentimes as Alzheimer's, specifically when we're beginning to see the cognitive dysfunction first, or as Parkinson's when we begin to see the movement disorder first. There is a 1-year rule. We'll talk about that in the next slide about what the proper diagnosis is. But the reason I began in Lewy body work is because these folks are oftentimes challenging, oftentimes misunderstood. We don't have the proper diagnosis. We don't really know what we're looking at. We just know it's not quite Alzheimer's. There's something else going on. And typically when people will take one of my classes, we'll begin to see that light bulb go off and they'll begin, aha, that's what we're beginning to see. So in our long-term care communities, I was beginning to see that oftentimes because of a lack of education, some of our communities knew how to work with Alzheimer's, but not so in the more challenging disorders. And so I do a lot of education with frontline staff, specifically in our long-term care communities, so that we can give better care going forward in these more challenging disease processes. You'll notice on there, I put responsive behavioral presentation. I like that term. And these folks have gotten labeled in essence as behaviors or aggressive behaviors. They are telling us as a response to their stimuli around them. Are they in pain? Are they soiled? Are they hot? Are they cold? Are they hungry? Does something just not feel right? And so therefore it's our job to figure out what is going on at its very root cause so that we can fix that. But it is a very challenging disease process. And we'll talk about some of those core features and supportive features in just a moment. Very rarely, but it does happen on chromosome 5, there can be a genetic link to Lewy body disease. So we're beginning to see a little bit of that as well. So some of the criteria for diagnosis of Lewy body disease, at its very core, they must, an individual must have 2 or more of these core features to have a probable diagnosis, and then maybe a couple of the suggestive or supportive features. So at its very core, difficulty with cognitive impairment, attention specifically with these folks, difficulty with attention, this executive dysfunction to where we see oftentimes those higher level planning or goal-oriented thought process. Visuospatial is very difficult as well. What's interesting about Lewy body disease is that memory is relatively spared in the mild to moderate stages. It's only within the moderate stages that we really begin to see that memory affected. Parkinsonism, some of that postural instability, maybe leaning to one side or the other, some muscle rigidity. I say bradykinesia. What that means is that slow movement, maybe this shuffling that we see, difficulty with gait. We also see oftentimes this expressionless face, a lack of tone in the face. And so we begin to see this lack of expression. Fluctuating cognition and abilities. That is one of those core features as well. It can occur very, very rapidly, whether or not minutes or hours. And oftentimes I hear families talk about the roller coaster of Lewy body dementia. Oftentimes very lucid, other times very, very difficult time with cognition and attention, this roller coaster we see. So it can fluctuate very rapidly. It can fluctuate very gradually, let's say even over days and weeks. Concurrent visual hallucinations, typically always visual, because as we talked about, it affects that occipital portion of the brain. So if you'll put your hand on the very back portion of your head, right above your neck, that's your occipital portion, and it affects that visuospatial portion of your thinking and processes. Where this really affects is what we see visually. I have about 80% of folks with Lewy body dementia have as a core feature in the very beginning, we see this early on, have visual hallucinations, although they can be tactile, auditory, olfactory, lots of different ways that this thought process can be so different. REM sleep behavior disorder. What's interesting about this is that about every hour and a half or 2 hours, your brain goes through these cycles of deep sleep and REM sleep, or rapid eye movement sleep. So within rapid eye movement is where your brain is, think of it as a computer. Your brain is rebooting, clearing itself out so that memories can be stored, so that your brain can have good cognitive function. Also during this time, the body paralyzes itself. So that the body is not doing work, the brain is doing all this work to kind of reboot or reset. Not so in these folks. With Lewy body dementia, Parkinson's disease dementia, what we oftentimes see is this thrashing during this REM sleep disorder. So think of it this way: if you are in your dream running from a bear because it's going to eat you, these folks, while they are sleeping and are in that rapid eye movement portion of their sleep, will kick, oftentimes bite or thrash or run. You'll begin to see them acting this out. So those are the core features of Lewy body dementia. Suggestive supportive features would be repeated falls. We see an awful lot of this with this disease process, what we call syncope, this in essence kind of blacking out. And sometimes they're episodic, which means that one moment they're sitting at the table eating dinner, the next moment they're slumped over in their chair because they've had this episode of syncope. We call 911, EMS gets there, find nothing wrong, they're perfectly fine. So we've seen that an awful lot as well. I will mention with falls as well, these folks don't have the muscle tone in which to catch themselves. So when they fall hard, and oftentimes affecting the head. Head goes first. So we see a lot of head injuries. Autonomic dysfunction. So the autonomic nervous system is the portion of the body that affects things that you don't even have to think about. When you're not thinking about breathing, your body automatically breathes. Your body automatically regulates your blood pressure, regulates collecting this poison that turns into urine in the body and excretes it from the body. I mentioned delayed gastrointestinal emptying, and this is really important for our folks that have pronounced Parkinsonism. What we oftentimes see with Parkinson's is we see this on and off. Medication is given on these 4-hour intervals. We oftentimes see that sit within the stomach, and it doesn't dump from the stomach to the small intestine, so it can be brought into the bloodstream to help with that rigidity and that muscle tone. So because of this autonomic dysfunction, we oftentimes see a delayed response in getting their medications in them. These illusions. So what the difference? A hallucination is a visual, auditory, tactile type thought process. Something is crawling on my arm and I actually feel it, or I hear a train coming down the track, or I actually see an 8-foot tall man with a square head that's purple. So think of it this way: your brain does not hallucinate anything it has not seen. We've seen a square. We know the color purple. We know what the number 8 is. We've seen a very, very tall man. And so oftentimes that vision portion of our brain jumbles all that up. I oftentimes, when I do a consultation, I will ask the family about traumatic events. Have they been witness to traumatic events? What was their service like if they served in the military? This is important. Riveting bolts in an airplane stateside is a very different experience than being boots on the ground in Vietnam or Korea. And so I always ask about that, because oftentimes that brain relives those in these hallucinations. A delusion is a as a false belief. My spouse is sleeping with the rabbi. That one, cheating on them, spending money that there isn't there, that type thing, this false belief. An illusion, think of it this way. I oftentimes use this example of a coat rack standing in the corner. You've got a hat on top, you've got a coat hanging on the coat rack, and you've got a pair of shoes that sit underneath it. What do you normally think of? These folks would think that's a person standing in the corner. One other thing that is not mentioned here is oftentimes these folks will mention that they feel that someone is standing behind them, looking over their shoulder. And it's this feeling that someone is right beside or right off their backside. Capgras syndrome is very common as well. This is oftentimes called imposter syndrome. So I hear this oftentimes with spouses, that an individual that their husband just walked in the door, they've known them, been married for 50 years, all of a sudden, I don't know who this person is. Why are they in my home? It's not necessarily fearful. It's just they don't know them. They're not recognizing their face or their person. Sometimes it will last for minutes or hours. I've heard of it happening for a day or two. And sometimes it's very distressing for the care partner. Mood dysregulation, we see this an awful lot. Depression, anxiety, apathy. Apathy is, in essence, a lack of caring is sometimes how we explain this. Interestingly enough, apathy is one of those early indicators that we oftentimes see, sometimes 10, 15, 20 years before a proper diagnosis. And where CT and MRI is very important for as a testing for Alzheimer's disease and vascular, a PET scan is very important when diagnosing or giving a probable diagnosis of dementia with Lewy bodies or Parkinson's disease dementia. They're looking at the dopamine transporter uptake. They're also looking at this occipital lobe activity as well. So what does this look like for us in our own home as we're care partners? There is what's called a 1-year rule, very indicative of how the diagnosis is given. So dementia with Lewy bodies is diagnosed when dementia occurs before or concurrent or at the very same time as Parkinsonism. We see a lot of these tremors, muscle rigidity, postural instability, slow movements. Parkinson's disease dementia is given as a diagnosis when dementia occurs in the context of an already established diagnosis of Parkinson's disease. So you'll oftentimes hear the 1-year rule when it comes to Lewy body. So these responsive behaviors have oftentimes a delirium-like feature, fluctuating cognition, visual hallucinations and delusions, and then again, this REM sleep disorder. So we oftentimes see this insomnia. I hear a lot of family members, care partners tell me that they'll be up for 2 or 3 hours at a time, asleep for 2 or 3 hours at a time. And there's just this wave of 24/7, a lot of insomnia at night, a lot of excessive sleepiness during the day. And we oftentimes see restless leg syndrome in combination with this as well. What's interesting is that there's also what I hear care partners refer to as a twitch. You'll see extremities, arms or legs have this twitch as if it's this neurological jolt that goes through their muscles. So another presentation of this. So we're going to move on to frontotemporal lobar degeneration, oftentimes shortened to frontotemporal dementia. This is a huge spectrum of disorders. Oftentimes it was originally called Pick's disease or Pick complex. So lots and lots of initials up there. I'm gonna tell you what each one of these means. Frontotemporal dementia, motor neuron disease, Frontotemporal dementia, amyotrophic lateral sclerosis, or ALS, is part of this as well. Cortical basal syndrome, progressive supranuclear palsy, and primary progressive aphasia. So a lot of other related disorders as well in this. It can be, and oftentimes is, an inherited disease of first-degree relative. So if you have a parent or a sibling, it can be a lot more pronounced, and usually showing up in patients as young as their 40s. So when we talked about in our very first slide that not necessarily is this an old person's disease process, frontotemporal, we oftentimes see in younger folks, sometimes in their 40s and 50s. So it is caused by a mutation of a gene that makes tau protein, and what these are called PIC bodies. So in its very essence, the tau protein becomes altered, and it binds and stabilizes. It has difficulty binding and stabilizing cell components. And so these tau protein bundles up into tangles, and it chokes out the healthy nerve cells. So there's a couple of different variants that we see with frontotemporal dementia. Frontotemporal, of course, being your forehead right up here, temporal being, of course, on either side. So there is a behavioral variant, which is the frontal variant. Also right temporal is where we see this as well. It impairs attention, the difficulty in planning, or the goal-oriented type abstract thought process. And because it affects folks in their 40s and 50s, oftentimes a little bit younger, oftentimes we begin to think, if very first reaction is this is a mental health disorder. And so lots of impulsivity, lots of difficulty with judgment. There is also a language variant to frontotemporal. This left temporal variant, the left portion of our brain is really what affects language. And so what we oftentimes see in this variant is a lack of verbal fluency. So not only do we have trouble with input, we have difficulty with output. So having language come into us, hearing language, understanding language, figuring out what it all means, and then putting it back out, such as speaking or writing or verbally having difficulty with that language piece. What is interesting about these folks, because they have such difficulty with language and communicating to us, oftentimes a lot of these folks do become mute. So that language portion of their brain just is not working properly, and therefore can't get it in, can't get it out, and stop talking, stop communicating with us. So those symptoms do start at a younger age, typically. Now, I do see folks 70s and 80s get a diagnosis of frontotemporal, absolutely. But we do see some of those diagnoses in younger folks in their 40s, 50s, and 60s. Loss of insight, difficulty with judgment and impulse control. Oftentimes they seem very uncaring, like don't know, don't care. And so it's this lack of apathy. Doesn't really bother me. Yeah, whatever. And so oftentimes that's an early indicator as well. Some socially inappropriate behaviors, disinhibition, inappropriate expressions for the context of the conversation or the situation we find themselves in. Sexually inappropriate responses can also be part of this behavioral variant. Repetitive behaviors such as hoarding or gluttony, we see as part of the behavioral variant as well. I did mention ALS, which is amyotrophic lateral sclerosis, this weakening of the limb muscles. So either both upper and lower extremities, inability to swallow, and at the very end of the disease process, inability to breathe on their own. So some of the medications that are helpful for Alzheimer's disease, for vascular dementia, are the donazepam, which is Aricept. We oftentimes see memantine, which is Namenda. Those are very helpful in Alzheimer's disease, vascular dementia, very ineffective in frontotemporal, just simply do not work. So oftentimes, especially with the behavioral variant, we typically see as a frontline medication, we do SSRIs or antidepressants. Then we can oftentimes move into the antipsychotics or some other medications that will treat symptoms, even though we can't treat the disease process itself. So, all right, that has gotten us to the end of the bulk of information. I know that was a ton of information, and you're probably going to have questions. Here is my information if you would like to either look at other videos that I have on my website or want to contact me for a consultation. I'd be happy to do that. So we will go back to Rob. I need to stop sharing. There we go. There we go.
Super. Thank you so much, Sarah. Yes, that is a lot of information, and we understand that was a whole lot to throw out at everybody. It may take a few minutes for everyone to digest it, but we do have some questions specifically to some of the things that were discussed. In particular, one person is concerned about their aunt. She was just recently diagnosed with early stage dementia. Now, the diagnosis happened through a questionnaire and a telemedicine visit, so it was not an in-person. She recently had hip surgery. She is on a lot of medications. She's depressed and anxious, recently lost her husband. And so the concern is whether this really is a dementia diagnosis or not. She's scheduled for an MRI. And so the main question was, will an MRI effectively help with a diagnosis of dementia?
You've got a lot of things going on here. So not only is there a situational thing with a death, there may be polypharmacy. There may be some medications that can be causing some cognitive impairment as well. And the first one, my brain has failed me. The first indicator.
The hip surgery
you have a couple of
and medication.
There you go.
Well, yeah.
The anesthesia can also be causing some of this as well. Absolutely. So I am sure that the doctor is trying to rule out. We talked about those maybe blood work, some of those testings like a CT and MRI to try to figure out, do we see atrophy in the brain? Do we see this decreased white matter that could be indicative of something else going on? I'm sure they're also looking at all that blood work, trying to figure out some other things that might be going on, but polypharmacy, absolutely. There's a lot of medications that can cause some cognitive impairment as well. So there's lots and lots to weed through. My absolute favorite response is typically, that's a great question for your doctor. I'm sure once you get those MRI results back, they'll go over that with you and really give you a little bit more, a better indicator of what you're looking at.
So MRI is just one of the tools that we can utilize to help determine whether it is a dementia and what type potentially, or if it might be another factor that's being coming into play.
It's one of those tests that can be run that looks at the brain to see exactly activity in the brain that will give a good indicator if there's something that's not quite, quote, normal.
Great. You had mentioned when we were talking about vascular dementia, you talked about TIA. Can you explain what TIA is?
Yes, it's a transischemic attack. So in essence, think of it this way. It's not a heart attack, but it's a heart attack in the brain. It in essence has a, how do I describe this? It is, best way I can describe it is a heart attack in the brain. It is just a lack of blood flow, not a stroke. yet this kind of short circuit in essence.
And usually it's only lasts about 24 hours or so, and then the symptoms of it kind of dissipate.
Yeah.
We just talked about anesthesia, and we had a question pop up about that. When someone is having cognitive issues based on the anesthesia coming out of a surgery, especially older adults, because we know this is a real concern, is that something that will go away over time, or is it potentially that those are things that might become permanent with the memory loss and those issues?
Right. Anesthesia is a really, really tricky one. Some people bounce back really quickly, and then a lot of our older folks just simply do not. In essence, the brain and the body need to flush that out of the system. And sometimes I've seen it take up to a year before folks are themselves again after having anesthesia.
Okay. A couple questions about the Lewy body discussion that we had. Is Lewy body something that is genetic? That, with Alzheimer's, there is a part of it that is potentially genetic. There's a few folks that do have the propensity, that do carry a gene that makes them more susceptible to further in life developing into Alzheimer's. Does Lewy body fit in that same way? Does it have a gene variant that can cause it to come along?
There can be. So there is an abnormality of chromosome 5 that we have identified as having a genetic risk factor attached to it. So yes, we have seen that. Not all Lewy body diseases are genetic. But we see a very, very small portion of those having that abnormality, and that can be easily done with a chromosomal study.
Okay, so that was the other question. Is there a test that can be done to determine whether someone carries that variant?
Those are called DNA studies, yes, and a cytogenetics laboratory can actually do that test. It's a blood draw. They simply look at the entire spectrum of the chromosomal DNA to look at and see if there is a deletion or an abnormality attached to that. Interestingly enough, early on in my career, I used to work for a cytogenetics lab. So those are interesting to look at to see exactly what could be at play there. Yeah.
Well, let me ask you this. We see a lot of commercials for the genetics test that you can do at home. Spit on the swab, send it back in, and we'll tell you all these things that your DNA is going to show, not only your heritage, but whether you're susceptible to diseases and things like that. How reliable are those if it comes back and says you have 50% possibility of developing dementia? How reliable are those types of tests? And if not that great reliable, where do we go and get tests that will tell us, if we have this potential in our genes?
Right. Yeah, those are interesting. I don't know a tremendous amount about those, but this doesn't necessarily tell you absolutely you are going to develop this disease process. It tells you whether or not you have a propensity or puts you at greater risk for developing. I have not seen those types of tests indicate dementia. I do know that there are some swab or buccal swab tests that can be done that can indicate what class of medication, what class of drug would be most successful for you based upon your body makeup. And typically these are that class of drug that are antidepressants, antipsychotics, those types of psychotropic medications that instead of shooting in the dark, we can better indicate this class of drug would be better for you. I will say I did not touch on this in the Lewy body portion. However, these folks actually are the most susceptible to medication interactions, very, very sensitive to medications. And so really by using that buccal swab, some of our memory care communities here in town actually do that upon admission. will do a buccal swab to figure out, instead of shooting in the dark with a psychotropic, we can actually pinpoint the direct medication that should be used, and therefore we have better success.
Right. And as you mentioned, whenever in doubt, talk to your doctor. That, you know,
Always. Always. I'm not a clinician. I cannot diagnose. I cannot say this is exactly what it is. I can simply say, according to what I see, here are some questions you should ask your doctor.
Right. Fantastic. Another question about Lewy body. Since PET scan is an important way of diagnosing the Lewy body, is it true that Medicare will not pay for a PET scan?
Oh, wow. I don't get into the billing portion. So that is a great question for Medicare. It could be a great question for your doctor who's wanting to do a PET scan. I do know that they're on, I don't believe they cover SPECT scan or DAT scan, which is helpful in frontotemporal. So I believe we're getting closer to that, specifically when we're seeing a lot more diagnostic abilities in which to diagnose properly.
Mm-hmm.
I am unsure about the billing portion, but good question for Medicare. And the doctor's office may have seen or have history of that based upon your insurance. Will have you seen them successfully bill and receive payment for that?
Got a question about bipolar. And one person in particular who was diagnosed in their 30s as being bipolar, and was wondering if maybe they were misdiagnosed and it was a possible type of dementia, and wondering if medications can also cause dementia. Long-term use of particular medications can cause any of the dementias.
That is a great question. I don't have any particular studies that indicate that. I'm sure they're out there. I have not run across it. Interestingly enough, my first career was in mental health, very familiar with bipolar disorder. You know, I would imagine a full workup, blood work, any scans that there need to be, a visit, or a 4-hour really full deep dive into a neuropsychological report might be a better indicator of that as well. Long-term use of these medications, I will say a lot of our folks that have a diagnosis of a bipolar, schizophrenia, schizoaffective disorder who are on some of these anticonvulsants, that is a acetylcholine blocker. And oftentimes these folks do have difficulty with word retrieval, difficulty with language. It just blocks that ability of the neurons to talk to each other. And so we see that an awful lot in mental health treatment. But as far as a certain treatment causing dementia, I don't know of any specific studies that actually speak to that.
I do know that we're starting to see, for folks who have been living for several decades with HIV and are on the HIV antiviral medications that have been for 20, 30 years, that those are starting to cause some cognitive issues in folks. So, we're still very early in a lot of these discoveries and a lot of this research and what we're finding. So the fact that we are moved so far along just in the past probably 20 years is pretty remarkable. Going back to when we were talking about TIA, you got a quick question there on what are the effects in the long run of having a TIA episode, especially when it happens repeatedly. Is there something that's going to be happening in the brain that we need to be concerned about? And is there any things that we need to do to help prevent?
When we see repeated TIAs, absolutely, we begin to see damage to the brain. So that's a great question for a cardiologist to begin what long-term effects would happen because of this, but we see an awful lot with TIAs, repeated TIAs over time begin to have that cognitive impairment. Yeah.
And so again, always go back to talk to your doctor. If you got a concern, talk with the doctor. Since we were talking about the DNA testing, a couple folks were wondering, where can they get these DNA tests? Is there some place specific, or is it something they need to discuss with their physician on having that prescribed?
There is a lab that you can order these from, and for the life of me, I cannot remember what the name of this test is, but I'm certain in the day and age of Google that we could probably type in there buccal swab for indicators of psychopharmaceuticals, and you could probably come up with the name of it. There is a lab that actually will ship those out. Like I said earlier, there are some of our memory care communities that buy these in bulk and will do that swab on folks coming into the community that would give a better indicator of that. That's a great question. I can find you an answer.
Okay, great. Well, we will find an answer and we will send it out to everybody and let you know.
Find an answer. Yes.
Got a question. You talked about Montessori techniques for dementia. Where can a person find resources for that?
I love Montessori. So as it relates to dementia care, this is surrounding the principles of dignity, respect, and equality. So in essence, we, and that's one of the reasons you've heard me continuously not use the word caregiver. You've used me use the term care partner. When we talk about caregiver, which means there has to be a giver and there has to be a taker. So when we talk care partner, we're working together for the dignity, the respect, and the equality of the person that we are partnering with to provide care. So we are asking them their input. We are continuously providing adult activities instead of childish activities. We are constantly working with those abilities that they have retained rather than those things that they have lost. So the International Council for Certified Dementia Practitioners, Dr. Cameron Camp, is the guru of all things Montessori as it relates to dementia care. That's where my certification comes from. And there are a few dementia care communities here in town that practice a Montessori method. When done and done correctly, it is beautiful to watch. And I'm a big believer in Montessori. I will also say that there is a 12-part series that Dr. Camp is embarking upon. I believe it started last month, but you can still catch up. So every single month, they are doing a training, a 1-hour training on the principles of Montessori. If you'd like me to find that link and provide it to you, it is $25 per class. If you buy all 12 at one time, you get an autographed copy of his book.
Great. That would be wonderful. So folks, we're going to be sending you even more information after the session. Got a question about alcoholism and dementia, the connections there. I know that there is a type of dementia that is related specifically to alcohol abuse. So can you touch on that?
Yeah, that is called Korsakoff's. And so typically, yes, long-term alcohol abuse can cause not only damage to the liver, but damage to the brain. And so we do see this from time to time. We also see this in combination with the other dementias because these folks are trying to self-soothe or trying to cope with some of the cognitive loss that they are experiencing. So we see this from time to time with other dementias, but in and of itself, it's called Korsakoff's and is an actual dementia caused by damage to the brain from long-term alcohol abuse.
Yeah, your physician will always tell you everything that goes in your mouth at some point ends up in your brain, whether it's medications, alcohol, whatever it is. So, continually drinking is not going to just affect your liver. It's going to affect every portion of your body.
Well, and I did list it under nutritive deficits. When you're ingesting alcohol, you're not ingesting water. You're not ingesting some of those, maybe a fruit juice that could lead to nourishing your body. You're simply putting, for lack of a better term, a poison in your body that is not nourishing your body over and over again. So there's just, unless you're still drinking on top of your 8 glasses of water a day, but most people do not. They'll sit and drink beer after beer after beer, or hard liquor, or that type of thing. Yeah.
Right. Got a really good question here. Where does mild cognitive impairment come into this scene? What is that? How is it different from dementias, and how does it relate?
Think of it as a precursor to dementia, is oftentimes the way I describe it in layman's terms. So it is something that you notice, some things that something's not quite right. However, it's not, in essence, at its very core, full-blown dementia. Oftentimes, on an MMSE or a MoCA score, it is 27 and above. 27 to 30 is normal. 21 or 22 to 26 is that mild cognitive impairment. We're saying that there's something that's not quite right. However, it's not a full-blown brain death, which is dementia.
Okay. And that's testing that can be done by neurologists, and again, have your physician make a referral.
A quick MMSE, or my favorite, which is the MoCA, which is a Montreal Cognitive Assessment, is my favorite, simply because each test is very specific to what it's looking for. One tests language, one tests executive functioning, or one tests visuospatial. They're all looking for something different, and just because you get a certain hardcore number doesn't mean that overall you have difficulty. It just means you have difficulty with that portion. So I like the Montreal, the MoCA. I think it's a more comprehensive test. And for the MMSE, same questions every single time. People can, in essence, study for it. So right before they go into the doctor, they're running through their mind, what year is it? What month is it? Who's the president? And so in essence, you can study for it, and therefore it gives skewed results.
Right. We touch a little bit on medications, talk about, especially on Lewy body, that there were the medications that are available for Alzheimer's and dementia are not effective for that particular dementia. What's happening on the medication front when it comes to dementia care? Or do we have the potential of some new medications? Are there medications that actually do anything at all that are available? What's the prognosis of someone who is just getting that diagnosis? Is there any hope with medication that can help with dementia?
So in essence, we can't cure it. We can't fix it. However, what we can do is slow down. In some cases, we can slow down the progression. And it's not necessarily like we're stopping it in its tracks. What we can do is we can treat the sign and symptoms. We can use Aricept, Namenda, Exelon. The new one is Nemziric, which is a combination of Aricept and Namenda. So what we can do is give you a longer period of best time. So there are many medications or drugs that are on the horizon that we are looking at. The more we know about the brain, the better that we can treat these types of disease processes. There are many coming, I have heard, but at this point, that's we can simply make it as good as we can for as long as we can. And at a certain point that we get moderate to advanced stage Alzheimer's disease, vascular dementia, specifically with Aricept and Namenda, at a certain point, it just stops working. And therefore, at that point, ask your doctor, but absolutely, I've seen over and over and over again that it does no good to continue to take a medication if it's not giving you the best function that you can. The Exelon patch I typically see with Lewy body, Parkinson's, really good in Parkinson's disease dementia. And then none of these medications, we can use some psychotropics when it comes to frontotemporal.
Right. And as you mentioned, early diagnosis is so important. I remember very specifically one neurologist who gave a presentation and said that for most people, when they start really noticing the symptoms of dementia, their loved one is already about mid-stage. And, at that point, the medications don't do any good. His analogy was, it's like putting gasoline into a car that has no engine. And so you're just, wasting the medication at that point because it's gone beyond the point where the medications can do any good. Got a great question here about Alzheimer's disease. Is it still true that the only real way to diagnose if someone had Alzheimer's disease is postmortem? We've always heard that it's looking at the brain after the person passes is how we can make that diagnosis. Or is the MRI that we have now available and those types of things giving us a good indication?
So 100 absolutely percent postmortem. Absolutely. But what we can do is we can give a probable diagnosis, and we can rule out every single thing. We can look at what the everyday responsive behaviors are. We can look at some of these CT, MRI, and we can pinpoint it pretty quickly and pretty accurately. However, when we just can't with 100% certainty say, absolutely, this is what we're looking at until postmortem, is because we need to look at those slides. We need to look down at the very molecular level and see exactly what we're looking at. But we can get pretty close.
Yeah, we've come a long way in the past several years. There's a long way to go, but there's a lot of research and a lot of things that are being discovered every week, and so we're moving forward. Got time for one more question, and I really like this one. Was asking, we're seeing diagnosis of dementia more often, and we're seeing it even earlier in folks. Is there something in the Western culture that is causing more people to have dementia? Are there lifestyle issues that are catching up with us later in life? Or is it that we are just advancing with our medical knowledge and diagnosis, and we are being able to diagnose it more accurately?
Yes. In a very simple core, yes. So not only are care partners doing a phenomenal job at noticing things and going to the doctor for a diagnosis earlier, the doctors are getting better at diagnosing it as well, truly looking at what they're looking at. And some of the research says absolutely no lifestyle link. Then others will say absolutely there is. We are at its very core sicker, living longer, we're fatter, we're taking more pharmaceutical medications. And here in our Western culture, absolutely. Specifically, when we talked about those risk factors for vascular dementia, age, diabetes, all these other things, all these factors, BMI, absolutely, is your adipose tissue around your middle contributing to some of these things as well. I think it's a multifactorial question and answer to that, but it's very core. Yes, all of those things, all at the very same time.
Yeah,
That's my
w-
opinion.
when I have the opportunity to speak to groups of older adults, and we always get questions about memory loss and dementia because it's something we hear so much about, and it's a very scary thing. I look at my parents who are in their 80s, and they were children of the Depression, so they know the value of a good meal. They stay physically active. Even though they're retired, they volunteer a lot. They go to church, so they're staying socially active. So they're taking care of their social, their mind, and their physical body. And so, we're seeing people living so much longer, and my parents are an example of that generation who are living healthier and longer. You look at my generation who, grew up in the 80s, and what did we do? We sat on the couch, we played video games, and we stuffed our face with Cheetos, and still continue to do those things. Or we spend our entire day doing this instead of actually talking with a human being. And so we're setting ourselves up for not a great rest of our life if we don't start paying attention to those lifestyle changes. And we've seen a lot of reports recently that say even into later in life, making those changes have a significant positive effect. So even if you have been the couch potato who played video games for the past 20 years, starting and exercising even into your 60s and 70s can have very positive changes on your lifestyle.
If you're going to change one thing today and take from this is to up your exercise. Walk around the block instead of hopping in your car and going 4 blocks down to the Walgreens, put on your tennis shoes, take a walk down there and take a walk back. Absolutely. Just a little bit more exercise per day does phenomenal things for the brain.
Yeah. Going to slip in one more quick question here. Someone who is a care partner for their partner who has Lewy body, and they're concerned about when the time comes that needing to move into a long-term care community. How difficult is it, especially here in Central Texas, to find a community that will take somebody who has Lewy body because of the issues that it brings about?
You have hit my hot point. This is why I got into Lewy body work 5 years ago. Absolutely. Because it is misdiagnosed. It is very challenging and so misunderstood. My hot point was when I began to see some of our communities that were not properly trained in Lewy body dementia. When they did not know what they were looking at, they either chemically restrained or they sent out to the hospital and refused them back. So you have hit upon my point here that my husband and I began our own elder care consulting agency 3 years ago, specifically to help the more challenging dementias. So yes, there are a handful of communities in town that do Lewy body and do it well, do it really, really well. So those are my go-tos when we're looking at this disease process. They're well-trained. I do a lot of training specifically with frontline staff on what is Lewy body dementia, what can you expect, how can we give better care going forward. So absolutely, I'd be happy to chat with you about that. Please reach out to me. I can walk you through that. When we do a consultation with a family, we don't spend 15 minutes on the phone and then give you a list of a dozen communities. We're truly going to spend about an hour or two with you to fully figure out the entire dynamic of what we're looking at. Oftentimes I get clinicals where we're really deep diving, and then we're going to match you with the community that will be most successful long term. So, but that's a great question.
Yeah, and as a reminder, Sarah's website is seniorlivingadvisorsaustin.com. And you can contact her directly and she can help you out with your journey. You can also give us a holler here at Age of Central Texas. You can also contact Riverbend Church. They can help make connections for you as well. We mentioned yesterday our friends over at the Area Agency on Aging of the Capital Area. They also are available for free to help you out in addition. the main thing we want you to take away today is if you have concerns, if you are worried about your care partner, if you're worried about yourself, ask for the help. Talk to your doctor. Talk to somebody, look for those answers, look for that help. There is never, ever, ever anything wrong with asking for that help. Sarah, we are out of time, but we want to thank you so much for sharing your expertise. You are such a great wealth of knowledge and information, and we so appreciate you being so kind in sharing what you know. We'll be back again tomorrow, 10 o'clock in the morning for our next session. We hope that you are able to join us. Keep your eyes out for the email with the program. Remember that we are going to be sending you the link with all of the recordings, and we'll send you the PowerPoint from today because there was a lot of information there that you're going to want to have. And we are here if you need us. We will see you again tomorrow, 10 a.m. for our day 3 of the GPS Navigation for Caregivers Conference. On behalf of H Central Texas and Riverbend Church, and Sarah and all of our folks and our sponsors, we thank you so much, and we hope you have a wonderful rest of the day. It's going to be nice and warm. Put on your tennis shoes, go out and walk and get some exercise. We'll see you tomorrow.